this is a consolidation talk to try to regroup what we have learned in the last few years. And the next slide tells you a little bit, and I also will age me, because this is a tricky font. And yes, cellular therapy is the final frontier. It's everywhere now. But I also wanted, to give you a little bit of the background where this started and how it started, because I think it's fascinating. And still to this day, 70 years later, it still permeates what we do. So we're going to go a little, through everything, and I'm going to take small deeps into some aspects of cellular therapy. So the first thing is, what exactly is cellular therapy? So cellular therapy is whenever you just transfer live cells that has some function that you're looking forward to into a patient. That's it. This is cellular therapy. It can be from the patient to the same patient, or it can be from a donor to the patient. And then you have the other concept called gene therapy, which is different. In gene therapy, you transfer a piece of the genetic material, right, into a specific cell of a patient body. And what you're trying to do is to treat a disease or prevent a disease with that. We do that a lot with enzymatic defects, and there are some approved. Bluebird and Vertex are coming for, hemoglobinopathies. We're going to be working with them here as well. So it's a different concept, okay? But it's all under the same umbrella because they share toxicities and especially a lot of auditing and data management. So in oncology, they were developed to attack tumor cells. And why? Because all of us, you're probably aware, we develop cancer cells on a daily basis throughout our life, but our immune vigilance is good enough to keep on removing them. With the senescence of our immune system, some people develop cancer because some of those cancer cells just go unrecognized. And with that, you're just giving the possibility of reestablish that immune vigilance, either through an allotransplant or CAR T, which is also what I'm going to be saying. What I think is very important is to remember that these are living drugs. The moment you unleash them in the vein of your patient, they're going to go where you program them to go, but also where you do not want them to go. And that's the problem. So on the other side, what is a hematopoietic cell transplantation, or HCT? So I like to call it as a transplanter the mother of all, but the CAR T cell specialists will really not agree with me. But this is a procedure during which you take stem cells from any source, and then you give it to a recipient, right, with the intention of reestablish a hematopoietic system. The goal is to give a new immune system and reestablish exactly what I just said, immune vigilance. So then we're going to have to discuss stem cell origin and the source, which are different. Don't forget that why this keyword of stem cell is so important. Stem cells are pluripotent cells. They can differentiate in different lineages of cell, and this is also very important to keep in mind. So it can be autologous from the patient to the patient, allo or allogeneic. They are collected from another person. And obviously, you're going to think, well, we have to match them. Correct. And this is one of the hurdles of the advance of the science. And this person can be related or unrelated. So this graft, again, this collection, this bag that you see at the Be the Match is full of stem cells, and it's also a living drug. And in this case, has no predetermined specific target. So it's totally different. It's much better in some sense, and it's much worse in other sense. So what are the types that we have? So the name have changed a lot in the past 8 years. Adaptive cell therapy, cellular immunotherapy. So now we are with immune effector cells. And we are trying, all of us, to adopt this name for all those cellular therapies. So again, those are cells that are used to modulate an immune response for a therapeutic intent. It can be in cancer, so solid tumors, heme malignancy, and viral infection associated malignancies as well. Whatever we can target and that's efficient, we do it. And in the next for cell type, we can have also dendritic cells, NK cell, T and B, but we also have T cell based adoptive therapies, CTLs, right? TILs, which are tumor infiltrated lymphocytes, and MEALs, right? Which is also another one that you capture from the tumor. And I want to close a little bit the focus on TILs because we have an expert in the house, which is Dr. Gibney, who has been working for more than a decade with TILs, specifically for melanoma and IO events. And we're going to talk a little bit about that as well. And then what do we do with these T cells that I collect? Then I engineer them, I change them, I make them do something that I want that they were not doing before, and make sure that they don't do something I don't want that they were not supposed to do. So that's why this is definitely a little bit like Star Trek, right? And you can have modified TCRs, which are T cell receptors. And keep in mind that we also have, because this question comes, mesenchymal cells, which are also used, especially for the healing properties that they have and modulatory properties. They are not part of cellular therapies. They are part of supportive care. And that's a very important supportive care. And I will be not talking about that today. So what are the most common products that we have? We have one called DLI, which is actually lymphocyte infusion, right? And those are selected from that allo transplant that we want to infuse in the patient. If there is any problem with the disease trying to come back, the graft is not working well. So those DLIs are there for quite a while, already for 50 years. We have CAR T cells therapy, which are the one that you hear the most about, and therapeutic vaccines, dendritic cells that are making vaccines so we can fight cancers as well. So a little bit of the historical perspective. So we call all of this in the beginning bone marrow transplantation, and you're going to see that bone marrow not really nowadays, it's a peripheral blood collection, right? And how did it start? It started with the atomic bomb, and people got exposed to a huge amount of radiation, and we found out that the marrow were just wiped out, and they had no cells, and they would die of bleeding and infections. So that's how it triggered the thoughts. How can we actually help the survivors? On the other hand, and I want to make the differentiation here, we have the autologous transplantation, which actually is very different because it's from the patient to the patient. And this is used to consolidate the response in order to prolong the cancer remission. Very different concept. And it's also used, which is very important, and we're going to try to work on that as well, is autoimmunity. It resets the autoimmunity because of the drug that we use for the condition. Another important information is total body radiation. So we found out that this eliminate leukemic cells, and it didn't cause irreversible damage to the other organs. And also the importance is because the total body radiation eliminates cancer cells from sanctuary sites, which are the brain and gonads. And to this day, we still use it in transplant, and quite a bit as a conditioning regimen. So the first successful transplant was in 1956, not that long ago, right? And it was done with identical twin. One twin gave to the other. Right away, you can tell me, wait a minute. If they're identical twins, their genetic material is the same, right? They are carrying the same immune vigilance. Yeah, you're right. And guess what happened? The cancer relapsed because the immune vigilance was not that good, right? But that's why we don't do it nowadays, unless you're trying to prolong survival or do something else that is not to do an allo, to reconstitute a different immune system, because it's not going to be different. We owe that, to Dr. E. Donald Thomas from the Fred Hutch. He is the father of all of that, and it's quite interesting. There is a very nice book that was, released last year. And if anyone is interested, please shoot me an email, and I'm glad to share with you. It's fascinating. The story of that is told in detail. In 1960, immune cells are shown to protect mice from cancer. Why? Because they see that it kills cancer cells, and the exact type of cell, however, is not yet known. So then you have here in 61, Jack Miller at the University of London finds out that T cells are developed in thymic gland, and they are involved in that control of cancer. And then comes 10 years later, almost, the first true allogeneic transplant with matched siblings. So they're not identical anymore. And then starts the field of allogeneic stem cell transplant with HLA matching and all the hurdles that it carries as well. In 1986, Dr. Steven Rosenberg at the NCI treats patients with tumor-infiltrating lymphocytes, which we're going to have approved soon. And by fall this year, we're going to start doing them here for melanoma. And this is a picture of Dr. Rosenberg with one of his patients that he cured through that technology. And then in 92, you start having the T-cell engineering. And this starts at MIT with the immunologist Michel Sadlin. And retroviral vectors are introduced with some genes that can really shape and change the conformation. So they take a little piece of the antibody and then they connect it with the rest of the receptor. So this, as you know, antibodies are very specific in recognition. You glue them with actually what is in the membrane of the T cells, right? And then that cells can be deployed and look for what exactly that antibody was meant to do. And the first generation CARs is developed in 1993. And that's opened a new chapter in our history of how we deal with cancer. And this was Zelig Eshar in Israel. So here you have a very nice depiction of what they do.
The green cell you see here is a killer T cell of the immune system which is attacking the cancerous red and blue cell. You can tell when the killer cell has recognized the cancer cell because the two dots move around and contact the target. The killer cell then spreads out over the cancerous cell. Passing the video through a filter makes the killer cell look yellow and allows us to really see how it focuses on the cancer cell. These killer T cells are constantly hunting down dangerous cells throughout the body and destroying them.
So you just saw exactly what those CAR Ts do. That's what they do in life, but they're alive. So when you deploy them again, they do good and they do bad. So we have to learn how to stop them from doing a lot of bad. So let's start with the autologous-based products. So autologous meaning from myself to myself. We do transplants, but this, as I said, is a consolidative therapy. We also tackle autoimmune disorders, lupus, Crohn, ulcerative colitis, scleroderma, to try to reset the immune system and make them stop doing what they were doing. And engineering T cells, CAR T therapy, TILs and meals. So CAR T cells, which are the ones that we see the most, and we're already doing it here for quite a while. It's an ex vivo. We take the T cells, we take it out of the patient, and then we want the T cells, we do an artificial fusion of protease, and this is constructed from an antigen, as I showed you, with a signaling piece and a co-stimulatory domain, because that triggers the call of other T cells, right? And then those become cytotoxic T cells, and then they go behind what we want them to go is cancer cells. But guess what? Exactly because of what I said, we want to make sure that I'm able to destroy them if they really go rogue, right? So they have on switches for safety, and I can inject like cetuximab or anything that make them sensitive that I know the drug can target, rituximab also, and then they just die immediately, and then I can stop the process. So NK, as I told you, this is an allogeneic product, and they are now in clinical trials. We have a bunch of them. We have a clinical trial here open that is using NKT cells as well, or macrophages, engineer TCRs, meals and TILs, and the suicide gene, as I said, and also a lot of interleukins to make them deploy better and persist better, which is another problem. Here, the annual numbers of HCT recipients in the US. And you can see, looking at the autologous, because we are looking now at autologous, we see the green going up. And I want just to disclose that this peak that you saw here in the 90s is because in the 90s, there was some fake news, right? This is the new name now, the fake news that breast cancer could be cured also with autologous stem cell transplant. Guess what? Not true. Not true. So then it went back down. And then what happened next is, sorry, you started continue to go up. And then here you have COVID that hit. And then you have the cars that come. And we honestly, we don't expect this to go as high as it used to be. And I'm going to show you with the result of Zuma 7 why. And here we're going to talk later about the blue one. And you can see here the numbers of autologous that we did in 2020 and 2021 in the US, more than 10,000. So almost exclusively collected through peripheral blood. It's an apheresis process. Why I'm putting that in bold, that's another program. We have here the blood and marrow collection program. They have the machines, they do the collection, they do the mobilization. Then those cells are taken, sent to another facility, the CTMF, right? So which is a manufacturing facility where they're frozen in the MSO to stabilize the membrane. Most common disease undergoing autologous. I used to have myeloma and lymphoma in bold. We are left with the myeloma, maybe not for that long because CAR Ts have arrived, right? And lymphoma definitely is not in bold anymore because it just got displaced. As second line now, the CAR Ts made it. Evidence of benefit and active research is already there and it's already working. So refractory Crohn's disease, so a patient that had 30 bowel movements a day, as you know, is not unheard of, can go down to 8 or 10. And this, it happens and it's really, the patient is very grateful. And it's quite a simple procedure. Severe systemic lupus erythematosus, same concept, reset. And solid malignancy, this is approved and goes to your boards, right? We can do autologous stem cell transplant for germ cell, relapse refractory, and Ewing sarcoma for high risk. So this is a board question, don't forget. Standard of care. So hematopoietic stem cells, I wanted to also bring the slide here. They have a very, very, very special, characteristic. Because if you look at the numbers, there is 1 in 25 to 110 in the bone marrow. It's almost nothing, right? It's really minute, and they are really attached there because they niche in the bone marrow. But then I'm just telling you that we're collecting them in the blood through a catheter, and then goes into a machine, we spin it and remove part of it. So what happened is, you can see here, we do what we call the mobilization. We give GCSF, right, or chemotherapy, and then the white cell goes up. And then we give another drug, which is plerixafor, which is a CXCR4 antagonist, which is reversible. And then guess what? This capacity that they have, which is niche, they have this homing factor. They are unable to go and reconnect in the bone marrow. We just block this. It lasted for a few hours. And then I put the machine and they retrieve that and give back to the patient the red cells, the platelets, everything else. So that's what we collect. So it goes from the bone marrow, then we take it through the leukapheresis, then I give to the patient, it's an infusion. And then how do you give it? It's a simple blood transfusion because those cells, they have this homing capacity and they just circulate and anchor in the bone marrow again, which is very specific. So apheresis conditioning, apheresis, the cell collection, as I told you, what we do, and then I give some chemo to the patient, which is called conditioning. And this chemo actually prepare the bone marrow to accept those cells. In the case of autologous, actually that chemo just ends up killing whatever is left, we hope so, behind. In lymphoma, it cures 50% of those patients. And in myeloma, which we use melphalan 200 milligram per meter square, it prolongs survival quite a bit. And the goals is to do lymphodepleting. This is an allogeneic. It's just get rid of the lymphocytes, right? Eliminate malignancy and really put that marrow in a profound immunosuppressed status. So the new cells, if they are allogeneic, can come and thrive. Very important, okay? Then they can go through engraftment, and sometimes we can even inject some cytokines to make that, to help them. The typical duration, for that engraftment, it's typically in an autologous about 9 days to 10 days, in an allogeneic a little longer, about a week longer. So this is to show you that autologous transplant is used in lupus nephritis. This is a presentation that happened in 2019, and it's basically the same process, okay? And GCSF, they give also cyclophosphamide. Cyclophosphamide is very, very good at killing T cells that are multiplying. Very good. So you're depleting the aggressor there. Then you give also ATG. Guess what? ATG is very, very good at killing more T cells. You're really trying to destroy the immune system. And then you just collect them and reinfuse what you had collected before. That milieu that you change with those drugs allows to do a reset of the immune system of that person. And then it improves the manifestation of the nephritis. And then you had 18 in 22 that achieved a complete remission, and 1 in 22 that achieved a partial remission. Some of them will relapse, right? But at least it really saves your kidneys for quite a while. And as you know, typically those nephritis are cumulative as you go. So this is the TILs. Dr. Gibney here will be the PI for this one when it comes. He's already working with it as a clinical trial, has a huge experience with them. This was actually shared last year, and it was published in the New England Journal of Medicine in December 2022. It was a phase 3 multi-center open label, right? Everybody knew what they were getting and randomized, so they had a way to just match, age and all the other characteristic of the patient. So both buckets would get the same thing. 168 adults, unresectable and metastatic stage 3C and 4 cutaneous melanoma. And they were looking to see, is it efficacious? Is it safe? When we compare TILS therapy to ipilimumab immunotherapy, 1-to-1. And then when in the treatment, first line or second line treatment in patients that had advanced melanoma. The primary endpoint, what they were looking for, is progression-free survival, to see how long that patient was able to remain in remission with the disease, which, as you know, is extremely aggressive. They also stratified. This is also how they did the randomization, just to put their typical mutation that needs to give different expectations, line of therapy and treatment center, because the expertise of the treating center was also evaluated. In the TIL group, how do we get those TILs? In the TIL group, they do metastasectomy, which the surgeon goes, take a piece of the metastasis, and then those T cells, those infiltrating T cells are removed, collected, sent to Iovance, who is developing it, and there they expand them and multiply them to make them kind of an army of T cells that can fight the cancer. Then you take the patient, you put in the hospital, you give what we call lymphodepletion chemotherapy, typically fludarabine and cyclophosphamide, using most of those CARs or T cell-based immunotherapies. And then you infuse your TILs that came back from the company, and then you start what we call high dose interleukin-2 to support the growth, the expansion, and the persistence. So it's very high dose, 600 K every 8 hours, maximum of 15 dose. A lot of instability, blood pressure, because there's a lot of cytokine storm. That's what happened. That's why you have to monitor this patient very closely. So conclusion was that the median progression-free survival was more than twice. This is the bar that you have here, as long as in the TIL group as in the ipilimumab group. It was quite impressive. The safety, grade 3 or more treatment-related adverse events occur in all TIL recipients. We are giving the T cells, right, themselves, they already fight and they kill cancer cells that release cytokine, and on top of it, I give IL-2. However, if you look at the other option, which was the EP, more than 50% also had side effects and immune-mediated as well, okay? And a lot of them, all TIL recipients, they had neutropenia. Not a surprise, they got chemo. So they go through a neutropenia and then to recover. Interestingly, they noted that there is an overall survival difference between men and women. And this in melanoma is not unheard of. It's observed. So men and women derive different benefit depending on which kind of therapy you give. So that also was noted again here for TILs. It probably has to do, with hormone and the environment that is different. So CAR T therapies, right? So what is that? So CAR T therapies actually is a T cell that expresses what we call a chimeric antigen receptor. The croquis, the little design that I showed you a while ago with the antibody, the intermediate piece, and the co-stimulatory domain, that's what it is. And we call them CAR. And now the latest generation, 4th and 5th, we call them TRAC. So they're huge. And they have a lot of other function as well. I don't know how long we're going to be able to grow them because it's the size of an SUV soon. I don't know how we're going to infuse them, but we call them CARs, right? So CARs combine the specificity of an antibody and the signaling domain of an effector cell. That's the beauty of it. And then you have a co-stimulatory molecule because it calls to that fight more cells as per the normal path. It enables an effector cell to recognize targets in an antigen-specific manner. And those that are autologous based, and that's why it's in italic, there is no immunologic mismatch. It's from me to myself. And that's why this is highlighted. We're going to talk about allo. So far, the most successful that we have are for relapsed refractory CD19 hematologic malignancies. Who are they? Large B-cell lymphomas, diffuse large B-cell lymphoma, mantle cells, follicular lymphoma, all this non-Hodgkin's lymphoma that are CD19 positive. So this allowed as a platform to enable the development of CARs-based immunotherapy using other immune cells. Remember, I mentioned NK, B cells. This is happening already. So here I wanted to share with you something that changed the paradigm and the standard of care that was in place for 40 years. For 40 years, first line R-CHOP, second line autologous stem cell transplant with some conditioning, typically BEAM. That was changed with the result that was shared at ASCO and the publication that came 7 days ago. That is ZUMA-7, which first they announced the progression-free survival, and now this is the overall survival that is shared. So that it was a phase 3 clinical trial, multi-center, open label, randomized, okay, survival outcome in large B-cell lymphoma. So you have the double hit, a lot of different kinds of, and they were either in CR or in PR. So what did they compare? Axicell, which is the Yescarta product, Kite, which is the CAR, and the other one was the standard second line. And I just shared with you, the second line was transplant, right? So what do we do with the transplant? We give typically 2 or 3 lines of chemoimmunotherapy, can be ICE, DHAP, some kind of very strong chemotherapy, right? And then we collect them, and then we do the transplant with a conditioning, typically BEAM. So that's what they were comparing. Again, that standard here was in place for 40 years. 359 adults refractory to first line or relapsed within 12 months of the first line, because it's also categorized as, refractoriness. And the median follow-up of that group was 47.2 months, so quite long. Important to mention, all patients had some kind of adverse event, right? CRS or ICANS, which is a cytokine storm of any shape or form. But no new death was reported, occurrence in the primary analysis that was on event-free survival. Progressive disease were the cause of death in 43% of the patients that received the CAR and 54% for the one that got the standard of care. Grade 3 cytokine release syndrome occurred in 6%, right? When this is high All of them will have some kind of fever, something like that. So grade 1, 2. And grade 3 or more neurologic events occur in 21%. Okay, this is important to mention because Yescarta, we know, can give quite a bit of neurotoxicity, and we are ready for it. So we have to deploy steroid quite early. And we already have data to show that this does not mess up with the efficiency of the cells. And those are the curves. Nice curves, right? Really separated, as you can tell. So in orange, you have the axis cell, and this is the standard of care. Overall estimate, 4 years later, definitely different. Okay, and very significant difference. And a p-value of 0.03. And more data, obviously, will be published as we go. Let's not forget that all those companies that do the clinical trials are mandated to report long-term follow-up for at least 15 years, because we need to learn. And this is part of the complexity of what we do. And here the conclusion that happened, this is just to show you the progression-free survival that was already published and continue to be meaningful. If you look here, this curve is still separated here. And the hazard ratio for disease progression or death was 0.5. So it's really 1 to 2. It's very nice. Conclusion, at a medium follow-up of 47.2 months, Axicel, which is a CD19 specific CAR, as a second-line treatment for patients in early relapse refractory large B-cell lymphoma resulted in significant longer overall survival than what we had before, and 27.4% lower risk of death at 5 years than the standard of care. So this now is what we call the standard of care, first line followed by CAR. Now we have to convince the insurance company to all give us that. That's next step, right? It's a bigger fight most of the time. And this, you're gonna tell me, but you just told us that we have to collect, we have to have auditing, data entry, we have to check the data, we have to assess, safety. This is a lot. So we have a lot of different entities that do that. The CIDR is under the CIB MTR. It started in 2015 to start collecting. CT stands for Cellular Therapy Task Force. They started talking and said, guys, we need to get together and collect this. The approval of Kymria and Yescarta came in 2017. And this is when, in the between, they launched the Cellular Therapy Registry. This was through the Moonshot grants that they had at the NCI, and that started funding that, and it continues. And now you have, which is very nice, the EBMT, which is the European Bone Marrow Transplant Association Consortium, also joined, and the Japanese platform also is there. That is, for all of us, including the patient, a tremendous advantage, because this data and this repository allow us to go back and implement changes that can improve further the treatment and what we are doing. This is of paramount importance. What I want to show you also here is that in 2020, we had 2,000 cars that have been infused, and I'm going to show you soon. Keep this number in your mind, where we are at now. And those are all the cars that are already approved in the US. Quite a bit, and there is more coming. And those black bars are the black bars of when the long-term follow-up started. So those are the new numbers. Those are the infusion, the number of CAR-T infusion, 2016 by 2021. A year later, we are now at 6,343 patients and 6,624 infusions. This is what we call an explosion, right? Because that number I showed you was in January 2020, and now this is mid-2021. So this curve is only growing and will continue to grow, right? And it's very, very effective, right? So indication, so who is getting CARs nowadays? This is just a pie chart showing you that most of them are still the large B-cell lymphomas. They were the first in the market, the first that we had. And now we have behind the ALLs coming. Unfortunately, so far, it's 25 years old, the limit of age to get them. But multiple myeloma, we are expecting that this is another one that will explode with the Beckman Carvykti. Interestingly, this is now where we are right now. Only 14%, right, of clinical trials are actually giving CARs to the patient. Most of them, 86, How many centers in this data collection? 195 total. US contributes to 95% of those. And please look at the age here that we are giving CARs to. I want just to make you aware, 90 is the new young, okay? Don't come to me and say, oh, this is 65 years old. Forget it. We are doing allo to 70 plus. We are doing autologous close to 80, and we are doing CARs, I kid you not, 91. And you're going to tell me, are you guys nuts? Well, they're chosen. They are special 90s, right? They have very good life. They go, they play tennis, they're outside, they take care of themselves, right? So an encouragement for your patient that are young, say, please take good care of yourself so you can get CARs later on, right? So here the distribution by age, again, very interesting. And then I just want to point out, and as a person that have started, I have done early clinical dev in industry, this is a huge gap. As you can tell, in non-commercial, only 28% of the patients that are enrolled on trial 65 and plus. It's a big fight. It's a big fight. They believe that this can ruin their product, but then at the end, you have disconnect data out there. So this needs to be improved. If you look at the commercial one, 40% almost are 65 and plus. Well, is that a surprise? It shouldn't, because cancer, again, is a disease of the older age, right? That's when our immune vigilance goes down and all the cumulative effect of what we got hit with starts to take shape. So what are the limitations, though? So you need to have a center that can do leukapheresis. We are very, very fortunate here to have the largest collection center in the country, which does an amazing job. Necessity for shipping to and from the processing centers, those companies, they open new processing company all the time because this is a funnel, and this is what we call the chain of custody, highly regulated and problematic, not problematic, but highly regulated, and you have to make sure that the temperature, you know exactly where you track. They have tracking device companies that tell you exactly where the cells are. This is a huge liability, right? Imagine. You take my cells and you carry them somewhere. I don't even know where my cells are. Are you kidding me? So you have companies devoted to just tracking them. Time requirements for product manufacture and clinical release testing is typically about 4 weeks. That's a problem. If you have a high-grade lymphoma about to explode in your face, what you're going to do during those 4 weeks? Then you have to give bridge. But that also is going to take away part of the performance. I'm introducing where the next of the frontier will come, which is our, right? Previous cytotoxic therapies also impact the performance of those T cells. They are damaged because they got a lot of chemo. Some patients in myeloma can have received 15 to 20 lines of therapy prior to coming. This is a lot. And the cost is about $500,000 to have one CAR. So solid tumors. This is the next frontier for sure. And we are working a lot on that. And
Terry, I'm
yes.
sorry, but when you have that commercial column and you talk about the cost,
yes,
is any of that now insured?
yes,
Okay.
yes. But we are still not there yet. There's a gap at about 100K. But it's a lot of negotiation. And then you're going to understand why centers grow very slowly, because we have to allocate resources for that. And if they are Medicare, the struggle is even higher. Which, guess what? Most of those cancer patients have 65 and plus. So anyway, so for solid tumors, those are the big challenge. Which antigen? There are multiple antigen. On target of tumor toxicity is a problem. Hostile tumor immunosuppressed environment is there. Pancreas cancer is a typical example. And product manufacturing hurdles for timely delivery for the same reason as the other CARs, okay? And the persistence. You need to infuse them and make sure that they continue there so they can do the job. Okay, so there's a lot going on right now to find, cytokines that can boost that and help prolong the persistence of those cells. Allo product. So that's the same curve I showed you, but let's look now at the blue. As you can tell, it continues to grow, and this is the hit by COVID. It went down. We had to change a lot of the chain of custody, a lot of thinking around, but as you can tell, it continues to grow. We had 8,000 allo, about 100 in 2020, and in 2021, 100 plus, okay, than the previous year, and it's still going up. So this, I wanted to show you the allo by donor type. We have different type of donors, right? So they can be from the family, outside of the family. We can have cord blood here in red. We used to use them a lot before, very expensive. For an adult, we use 2 cords, 40K each, 80K just to begin with. Very fastidious to work with, but fantastic when they work because they're very naive, so they adapt to anything that you give them to, but expensive. This is a match related. This is family. Match unrelated, outside of the family, but same HLA typing. Haplo, this is half matched. This is growing exponentially. Those are the 2 major ones. So the mud or match unrelated, and the green, as you can tell, those are exploding. Why? Because we have better and better ways of controlling GVH. So it's allowing us to go out of the family and start working with less matched cells, which is great. So we are increasing access to allo. And finally, in this one here, the purple one, we expect this to grow further. Those are the mismatched unrelated. Why? Because we are showing now that the outcomes with the same GVHD prophylaxis is extremely effective and gives you very good outcomes. So we are expecting this to go up and up. So bone marrow harvest, this is an OR procedure. This is how it used to be. That's how we used to gown up and go to the OR. The surgeon hated us. They hate us because we displace them. And we are these people that don't even know sufficiently how to dress. We need help because we don't go there all the time. So, and we always that taking a big slot of their chunk, and we want the first time in the morning. Also want, so it's usually very laborious even to get the slot for our patient. Anyway, we still do this. This is the standard for kids still. This is how we do for kids. Umbilical cord, I told you. Minimal delay in transportation, I can get that in a week in my center. Peripheral blood collection is what is growing the most, even if there is higher risk of chronic GVHD. But it's so easy to collect, so easy. They can be in Germany, in Japan, wherever you say. And nowadays with COVID, we learned that we can cryopreserve them. They used to be fresh. I don't have time to tell you a big story about Sandy when the hurricane hit in New York and we had to drive those cells from California to New York with a limo. But it tells you how important this is. It was fresh product and it made it through the dark. And I was there at the bedside waiting for the cells to come and the army got involved. This is how sensitive this is. So relative proportion of allo and donor type in the US, I just want to show you exactly what is happening for all the patients. We definitely prefer to use a MUD, and this is growing more and more. The outcomes are very nice. The haplos also are growing, but then think, why is not growing more? Well, if my patient's 72, the sister and brothers are probably right there, like this. The father and mother, I lost them because probably they are in the 90s, so they themselves might have cancer. So this is the one here, the MUD, and the mismatch, the purple one and this one that we expect to see grow the most. Okay, and course, definitely it's more for kids now. We use only one depending on the weight cord. And this is indication. So, and that's it to explain that. I'm going to give you a little glimpse of what happened with AML in allo. This NHL used to be before, but this now with the CARs is third. So this in green autologous and allo in blue AMLs. Most of the patients with transplant are AML and MDS. This is what we need, and that's why we are so excited to have Dr. Rivera here. He's our leukemia specialist. Please don't shy away to tap from him his knowledge. He comes from Baylor, and he has a wealth of experience with leukemia, and this is going to really help transform our center. And here again, the trends, as you can see by age, right? We didn't use the blue 65. Look in the 2005. We really didn't like to do it. Now a third, they are 65 plus because we have better care for them, better supportive care, better conditioning, and they do fantastic. So who do we bring for allo, acute leukemia, lymphoma, and MDS? This is just a distribution, right? Most of it are leukemias and lymphomas. This is 2020. And bone marrow failure syndromes. Yeah, they have no marrows, so we have to give a new marrow. Hemoglobinopathy, sickle cell disease, which is something also that we are working on together with the new vectors that we have. We're going to have also allos for sickle cell disease. And this is just a little glimpse for AML. What are the outcomes? You're going to say, okay, you do the transplant, but they all die. Not really, not really. It depends how they did through the chemotherapy. You can see that here, and this is 5 years later, right? For match-related donor, very comparable to match-unrelated donor, right? And you have the numbers here because I thought it was easier also to see. This is between 2010 and 2020, and it keeps on improving. This is the 3-year probability of survival after an allo, depending on the disease setting. What is the take-home message here? The most important is to have a good remission. So MRD testing, there is no leukemia cells to be seen. And then they do very nice. More than half of them, they are alive and they're doing good. They're cured. This is unheard of, right? This is a cure. Allo is a cure. And factor influencing, and I want to the age, performance data, as I told you, donor, HLA match, CMV. But I want to also highlight here supportive care. We take it for granted. Antibiotics have changed. GCSF has come, right? Rooms that are special around us. This is very important. And here also, what do they die of? To share with you. You can tell that, organ failure typically by infection is still there. It's a big problem, right? But primary disease, especially in the long term, is there. So what does it tell us? Well, we need to have good ways of avoiding the disease from coming back. This is maintenance. What can we do? How can I have a deeper, complete remission? Those are the roles of testing for minimal residual disease. It tells me how deep is my remission. Very important. And I put here the haploidentical because we do a lot of haploidentical here. And I want to show you how well they compare to match unrelated. Haplo, only half matched, okay, family. So this allogeneic product, it's very attractive, right? Because it's off the shelf. You just produce them and put them there and wait for the call. Okay, oh yeah, I have a match for that. I can send you that. Healthy donors donate the cells, right? And much more cost effective because it's not tailored to only one patient. But there are some limitations and challenges because guess what? I just told you that you have to match those, right? So GVH, alloimmunization, the recipient will react against that card, right? And decrease persistence because of that. So these are the current hurdles. So toxicities, potentially severe, right? This is a safety issue. That's why the long-term follow-up is 15 years. CRS, ICANS, as I said, they can have B-cell aplasia. CD19 correlates with B-cells. They can get really depleted. The big fear was when they come back, those B-cells, maybe the relapse will come. The long-term follow-up showed that this is not the case. We have a wealth of strategy now to mitigate those safety issues, but the pricing isn't toxicity that remains. So this is the next obstacle that we have to work on. So in our transplant, what is the worst? So mucositis, but it's not that common. Cytopenia is going to come back. SOS, very rare, which is veno-occlusive disease of the liver. However, in bold here are the ones that are still there. Graft-versus-host disease, infection, and secondary malignancy. So we have to really, really pay attention to them and be able to manage them well. In acute GVHD, right? So it's an alloreactive donor. So the graft T cells recognize the recipient, the patient, and start attacking. Because that graft, the other one that killed all the cells, start really looking at the tissue that is around and start biting them off. So this is GVHD. It's a very complex immune process as opposed to CARS. It's not targeted to one. It's a broad immune system. So that's why it's more complex to control. 30 to 60% of patients will have some, but I have to caution you, only 20 to 25% will have what we call lethal GVHD. It's a minority of the patients. Most of them might have a little bit of a rash, and that's it, not more than that. And it's very intertwined with what we call the graft versus leukemia effect, because that same bulk of cells also fights the cancer. So you can't just eliminate them, which they did in some institutions. They used to do T-cell depletion. Guess what? The relapse rate was high, even if they had no GVH. And chronic GVHD. This is another disease. It looks very different. It's more not autoimmune, so scleroderma, the skin becomes very tough. It's very different. So here I want to introduce you to the HLA family. So this is how it works, right? So the degree of human leukocyte antigen mismatch is behind that GVHD, right? So we know that female donors to male recipient increase the risk. Female get pregnant, to this day, male not yet. So they carry with them a lot of those antibodies that were created because of that half fetus that did not belong to them. So this circulates. So there is an increased chance of having GVH. Total body radiation creates a lot of, lesions on the tissue. So this remains around, and the intensity as well. So this is just to show you that's typically what happens. You have a haplotype here, another one, and the kids that share, they can be donor to each other, right? But if I wanted to have a donor for this one, who can be a donor for this one, right? And then you have to look, and that's what we do. When we ask an MDP to look at that, we look at that. But then you're going to say, wait a minute, you're only looking at like what, 5 loci? Yes. So, of course, you're already thinking that you have the minor antigens. So where are they? We're only looking through a keyhole here, right? And only are those HLA. And this little girl, what is she seeing? She's seeing a lot of other HLA and other antigens that are behind. GVH is behind us, and the GVH uses those minor mismatches, and that's what really triggers the process. This is typical skin GVHD, and it's very common. This is the easiest to manage. We have very good therapy, including photophoresis, which we have here, right? And now future direction. So where are we going now, right? We are the final frontier, it looks like. So are the cars before or after transplant, or they are curing? Where the car fits in the treatment paradigm? I just shared with you for Zoom 7, we know that now they should be the second line. Okay, now we have to convince the insurance to give it to me, even if it costs $500,000, right? And if the patient doesn't get sick, because if the patient gets sick and goes back to the hospital, now we're talking about 1 million. Bridge, is it a bridge therapy to allo? Then they're gonna call us crazy. Okay, so 500 for the car and allo, you're going close to the 800K probably there. So that's what it's gonna cost. I don't know if you guys are aware, all our insurance policies, they have a cap. So please take good care of yourself and make sure that you have the money left to use all those, this arsenal down the road. And challenges, right? High risk of developing adverse events because of that. So how can we combine them? How can we mitigate those risks? And new technologies also are coming to try also to change a little bit that and change the profile of those drugs as well. So growing number cancer diagnosis is a fact. It's on us. We know that the life expectancy has increased, right? And we need also, and we are seeing increasing policies initiative. There is a lot, and there's a lot going on now in the Congress, even for reimbursement. I'm sure you're aware that AMA is suing the whole consortium of insurance companies because they keep on denying. And guess what? They deny and then reappeal, and then, oh, oops, it's 50% of them. Oh, no. We are paying. So this is a waste of time. It's very bad for the patient. It's very bad for the institution. It's a delay in treatment. And here, obviously, while we have clinical trial work on increasing, we need to give the opportunity in our centers to be a good platform to give access to those clinical trials to our patients. Nothing happens without that. The patients, right, needed to be on clinical trials. And then the big fight now is the companies are trying to secure some treatment facility where they can have a good alliance and really make sure that they get the pipeline going. So this is a cost analysis. It's already a little old. It's 6 years ago, just to tell you what it cost having allo and autologous, and the health cost, the hospital stay at 100 days, what it cost, okay, and the length of stay, what it represents, admission, readmission, complication management, and so forth. Thank you.